Good afternoon, everybody. I'm Rachel Sachs, the Senior Director of Education and Outreach at the Cancer Support Community. Welcome to our Facebook Live today. For those of you joining us for the very first time, let me tell you just a little bit about the Cancer Support Community. For more than 35 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help individuals manage the realities of this disruptive disease and get back to normal. Whether accessing our free services in person at one of our 175 locations, online, or over our toll-free helpline, you are getting a team of licensed professionals providing patient navigation, financial counseling, genetic counseling, pediatric support, and much more. Today, we're going to discuss advanced non-melanoma skin cancer. These include squamous cell carcinoma, basal cell carcinoma, and Merkel cell carcinoma. Some of you joining us today may think that the only way to get skin cancer is from sun exposure, but unfortunately, this is simply not the case. We are here today to better understand together all advanced non-melanoma skin cancers, who is at risk, what the causes are, and what treatments are available for you. I am extremely grateful to have with us today a leading expert who will help us understand the many complexities and myths with this skin cancer and also shed light on treatments and approaches that are being used to treat this disease. We are joined today by Dr. Emily Smith with the University of Missouri, Columbia. Welcome, Dr. Smith.
Thank you, Rachel.
Dr. Smith is a board-certified dermatologist and dermatopathologist specializing in the evaluation and management of complex cutaneous malignancies, including both melanoma and high-risk non-melanoma skin cancers. She leads the Multidisciplinary Cutaneous Oncology and Oncodermatology program at the Ellis Fischel Cancer Center. Her research efforts are focused on the early detection of skin cancer using technology to improve early diagnosis, particularly for communities without access to dermatologic care. She is also the principal investigator on multiple clinical trials for patients with complex cutaneous malignancies and serves in both national and international working groups and advisory committees, helping to improve care for these patients. Thank you so much for joining us. And we're grateful for the support of both Regeneron and Sanofi in bringing you this Facebook Live about advanced non-melanoma skin cancer. Let's get started. Dr. Smith, there are several types of non-melanoma skin cancers. The three most common are basal cell carcinoma, squamous cell carcinoma, and Merkel cell carcinoma. Can you briefly describe the difference between each one?
Certainly. So yes, I think as you mentioned, a lot of us think of melanoma when we think of skin cancer, but really the bulk of the skin cancers that patients make and that we see in dermatology are basal cell carcinoma, which is by far the most common cancer in the world. 1 in 5 Americans will make a basal cell skin cancer in their lifetime. It's usually very slow growing, tends not to cause problems for individuals, and largely is treated very easily with skin surgery. The second most common type of cancer in the world, but also skin cancer, is squamous cell carcinoma. Again, very easy to treat in a large majority of cases. There are a small percentage of cases, though, that can present challenges up front and that can spread elsewhere in the body. But again, that is the minority. And then Merkel cell carcinoma is, we lump it in our category of non-melanoma skin cancers, but it's actually a very uncommon type of skin cancer, a very rare type of skin cancer, seen most commonly in older individuals and or patients who have immune systems that aren't functioning properly. But all of these skin cancers largely are very, very much curable when they're caught early.
Okay, sounds good. Can you explain to our viewers what the difference is between early and advanced non-melanoma skin cancers what the characteristics are of each, and how is non-melanoma skin cancer staged?
Yes. So as I mentioned, a very, 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 very large majority of the skin cancers that we see are early and treated, very easily with skin surgery or other techniques. And that is what we would consider an early skin cancer. So something that is small, something that is not causing substantial symptoms for the patient, and certainly a skin cancer that hasn't spread elsewhere. What makes something advanced, and this is true for all three of these types of non-melanoma skin cancers. Advanced cancers can be large, so skin spots that are very, very large, making surgery more difficult. Cancers that grow deeper into the skin or grow into deeper structures beneath the skin. Cancers that involve important anatomic structures like a nerve, a blood vessel, a tumor that is involving the eye, the nose, the ear, would be considered advanced. A skin cancer that has demonstrated that it is trying to spread elsewhere, be it either in the skin, within the skin, or that has spread to a lymph node, or that has spread elsewhere in the body. And those would all fall into the category of advanced non-melanoma skin cancers. Perhaps, though, the most common category of advanced non-melanoma skin cancers are really our patients who have multiple. They have dozens of basal cell skin cancers or dozens of squamous cell skin cancers or both. And even though each one of their little skin cancers isn't advanced in and of itself, having multiple can create a more advanced scenario in which we need to treat patients a little differently. Staging is our sort of formal way to decide if a skin cancer is early or advanced. And so a lot of our skin cancers don't formally need staging. We know they're early and we treat them. But there are some features that we can identify when we're looking at a patient or we're looking at their biopsies under the microscope that can tell us this might have the potential to be an advanced skin cancer. And then we do formal staging, which means looking at the size of the tumor, looking at where it's growing in the skin or if it has spread elsewhere in the body. These are all features and criteria that we use to determine the actual stage of a cancer.
Okay, thank you. That was very comprehensive. So, a little bit digging deeper, like most cancers, we understand that anyone can get it. But who's at higher risk for each of the non-melanoma skin cancers? You did touch on Merkel cell and that
Mhm.
people that are older, I believe you said, and immunocompromised might be more at risk.
Mhm. Yes. So let's talk about immunocompromised patients because they do encompass a group of individuals that are at higher risk for multiple types of skin cancer. So people with compromised immune systems, meaning on medications that suppress the immune system, either for an organ transplant or another medical condition, or a patient with a hematologic malignancy, particularly chronic lymphocytic leukemia, CLL, suppresses the immune system just enough that these individuals can make skin cancers more readily. All the different types of skin cancers are seen more frequently in patients who have compromised immune systems, Merkel cell carcinoma and squamous cell carcinoma, as well as melanoma. And in patients with compromised immune systems, the cancers can be more aggressive. They can grow more quickly and they can spread more easily. Other risk factors for developing skin cancer in general are, exposure to the sun, sunburns in childhood, fair skin, lots of exposure throughout the years. A family history does not substantially increase one's risk for these certain types of skin cancers, non-melanoma skin cancers, aside from the fact that a fair-skinned individual is at risk. And so you may have the genes to be fair-skinned, which puts you at risk, but not in most instances, not a direct genetic link that puts ones at risk.
Okay. So I've heard that most skin cancers begin with a mark on the skin that grows or changes. Is that true? And what signs and symptoms should people be looking for? I know that people see something on their skin and often they ignore it, say, it's nothing, and then wait a little bit too long. Or on the other hand, see something and get very concerned and, go to the dermatologist when it's nothing. So can you give us some guidance about when we should be concerned and when we should seek medical attention?
Yeah, that is such a great question. So most skin cancers do start off as some sort of a mark or a spot on the skin, something you can see or something you can feel. Most skin cancers aren't going to be particularly painful at first, with the exception of squamous cell carcinoma. So a bump that hurts is always worthy of evaluation by a provider. A bump that is changing, or a spot that is changing, if it is new and it's getting bigger week by week, month by month, it looks different than it did previously, that needs to be evaluated. For basal cell carcinoma specifically, a spot that's bleeding without there being any reason for it to bleed. You wake up in the morning and you have a little scab on a spot that you thought was a pimple, and that scab just persists. That can absolutely be a sign of a skin cancer. I really like to talk about the ugly duckling sign. We talk about it with melanoma, but it absolutely holds true for our non-melanoma skin cancers. If you have a spot that looks like nothing else on the rest of your body, it's acting funny, it's an outlier, that can be a sign of a skin cancer. So change, pain, bleeding, and a clinical outlier, something that doesn't fit in with the rest of your spots or dots, absolutely warrants evaluation. And I would just say everyone doesn't, or most people don't want to feel silly coming in and having a spot looked at, but my goodness sakes, it's so much easier to send someone home and say this is an A-OK spot than it is to deal with a spot down the road that has become advanced when it could have been treated early. So get those spots checked out. Don't feel silly.
Yep, I totally agree. And I know that our health practitioners would absolutely rather see you and say it's nothing and reassure you than have you wait and it be something. So don't hesitate to seek your healthcare provider, whether it's your PCP, who likely is going to refer you to their dermatologist, your dermatologist, or a dermatologist, but absolutely get it checked out, feel reassured, and then you can get treatment if it's needed. And hopefully that's early on.
Absolutely.
Great. So we know there's a lot of steps before a definitive diagnosis can be made. And the reality is that some are more invasive than others. If a doctor suspects that a patient may have one of the non-melanoma skin cancers that you described, what's the process for making that diagnosis? What can your patients expect? And can you tell us about the different types of tests that a patient may be recommended to receive?
Yeah. So anytime a patient has a suspected skin cancer, and I will tell you, if you're seeing, most family docs get really good, primary care docs get really good at picking up on these spots. I see a lot of them. And your dermatologist as well can look at a spot and probably know it's most likely a skin cancer. However, even though we may be very confident, in order to diagnose a skin cancer, you have to perform a biopsy, which is a technique to take tissue out of the body or off of the body and look at it under the microscope. And so anytime we're diagnosing skin cancer, it starts with a biopsy. Thankfully, skin biopsies are relatively easy. In the world of procedures, it involves a little shot with numbing medicine, and the practitioner will either use a little blade to scoop or shave a piece of skin off, or sometimes we'll use a tool to take a plug of skin out, and sometimes we actually cut the whole thing out. It depends on the clinical scenario, but a very, very vast majority of the time, in fact, it would be the rare exception to do it. Otherwise, these are done in the clinic while the patient's awake. You go home with a Band-Aid over it, and it's a relatively easy procedure. Other tests that may be done once the diagnosis is made are going to depend on the type of skin cancer that's diagnosed. So if we biopsy something and we identify that it is a high-risk skin cancer, or there are other clinical features, as I had mentioned, size, proximity to an important anatomic structure, we may do further testing. And that further testing may be in the form of imaging or radiology, so x-rays, CT scans, PET scans. We may recommend taking tissue from other places. And so in some instances, when we know a skin cancer has a higher risk of spreading to a lymph node, we may actually recommend sampling that lymph node. So that's a test called a sentinel lymph node biopsy. And so, sometimes we will order additional tests that look at the actual genetics of the skin cancer, though that's less common at this point in our non-melanoma skin cancers.
So it could be as simple as going into the office and getting it taken out right there. But what I hear you saying is that depending upon what your dermatologist or primary care physician might find, then you might have to seek further testing, further evaluation. And that's when the staging comes in and you can determine what exactly it is and then what the next steps are.
Yeah. So a lot of times when we're initially making these diagnoses, we're in a data gathering phase. And you have to gather all the pieces of data which involve the clinical exam, where that spot is, what it looks like, how big it is, who the patient is, what their medical background is. And then the pathology, looking at it under the microscope. And then if indicated, making sure it hasn't spread. These are all parts of our data gathering phase. And once we have those pieces of data in place, then we're ready to talk about what's the plan, what's the definitive treatment, and is more treatment needed beyond that.
And then let's say that you have a patient that comes to you that has had a skin cancer before. I would assume that that would also resonate with the practitioner about what action to take.
Oh, absolutely. So once you've made one skin cancer, you are at risk for making more. And so it is a very common scenario that patients make multiple skin cancers. In a way, it's helpful because a patient who has made one or dozens of skin cancers, they get to know their spots and they know what a skin cancer looks like and feels like. And you get a very strong gut reaction when you've had one skin cancer and you think you're developing another. And so those patients, not only are they, more likely to come in and seek care, but as the provider looking at them, we're more likely to evaluate and biopsy those spots because we know that those patients really know their skin.
Okay, perfect. So before we dive into treatment options, I would like to talk a little bit about the multidisciplinary healthcare team that's recommended for somebody diagnosed with any of the advanced non-melanoma skin cancers that you discussed. Can you tell us what type of practitioner we hit on the primary care physician and the dermatologist? What type of practitioners are needed? What's the role of the medical oncologist versus the dermatologist? And how is determined who's the lead and the point person?
Yeah, so anytime you're dealing with an advanced cancer of any kind, and skin cancer, advanced non-melanoma skin cancer included, being seen by a team, a multidisciplinary team, can have profoundly positive impacts on your care, the patient's care. When it comes to skin cancers, the team can be quite variable depending on where the skin cancer is located on the body and what type of skin cancer it is. But in addition to the primary care provider, the dermatologist, the surgeons play a very large role. And so depending on where the tumor is located, you may be seen by a Mohs surgeon, who's a special type of dermatologist, specially trained in a special type of skin cancer surgery. A head and neck surgeon or an ENT physician may get involved, a surgical oncologist. So if it's below the neck, a surgical oncologist may be involved. In certain instances, if it's on the hands or involving the genitalia, plastic surgeons may be involved as well. So there's a large surgical component. As we've mentioned, your pathologists play an important role. So that's the person looking at the specimens under the microscope. For skin cancer, you'll often be involved with a dermatopathologist like myself. And then, radiation oncologists may be needed, medical oncologists may be needed. Those would be the doctors to administer systemic treatments. And then social workers and our nurses play a very, very, very important role in the multidisciplinary care of these patients, really helping us to round out the care. And a lot of times what they do is more important than what we do, making sure patients feel comfortable with their plan of care and helping to coordinate things for us. So the team is really vast. And it's really rewarding as a patient and a provider to work as a team.
Perfect. And I know that you mentioned the nurses, besides the nurses that are treating our patients, also often centers have nurse navigators. And I know that I had a personal loved one who was diagnosed with a skin cancer, and the navigator was absolutely essential, making appointments, getting him in, and making sure that everything was dotted and T's crossed and all that. So the team is really, really essential and can help just really supplement and make you feel like you're in a good space and give you that level of support.
Yes, it is so important when you're going through a big diagnosis like this and a relatively complex treatment plan that involves multiple different people and appointments and times and locations. And it's a lot to keep track of for anyone. And those of us who've had family members or been through the medical system ourselves, I mean, we know it's a tricky place. And so having a nurse navigator who can really be that patient's advocate and help them get from point A to point B, whether it's physically from clinic 1 to clinic 2, or, coordinating and seeing through their entire treatment plan. It's an invaluable resource for these patients.
Okay, perfect. So you touched on this a little bit, but we know that there's different treatment options for treating advanced non-melanoma skin cancer. Surgery you touched on, chemotherapy, immunotherapy, and radiation, to name a few. But can you tell us about any others?
Those really are the large ones. So, surgery is primarily our go-to, and most of the time surgery is going to be involved in treating a skin cancer. Radiation is actually a really wonderful treatment too. And in instances in which we cannot cut a skin cancer out, sometimes we'll use radiation as the primary treatment. Other times radiation is used as what we call an adjuvant treatment, meaning we've gotten rid of the cancer, but we want to make sure it doesn't come back. And so we'll offer radiation as an extra preventative mechanism. Systemic therapies are becoming much more commonplace in the world of high-risk non-melanoma skin cancer. And when I say systemic therapy, we traditionally think of chemotherapy, which is used sometimes, but it's becoming a thing of the past when we talk about treating skin cancer in general, including non-melanoma skin cancer. We currently use immunotherapy quite frequently, which is a way to stimulate the immune system to fight cancer. And then sometimes we use targeted therapies, which are medicines that specifically target certain mutations in the tumor and help to keep it from growing or spreading. In the low risk setting, we will sometimes use other treatment modalities such as creams or freezing. There are injectables, medicines that we can inject into tumors to help shrink them. So the treatment options really are vast, and having a good broad team of experts helping to manage these patients increases those treatment options for sure.
So you talked about the different treatment options. Can you tell us, in terms of the immunotherapy, systemic therapy, radiation, what are some common side effects?
Yeah, so with radiation, a lot of the side effects when we're dealing with skin cancers are going to be skin related. So healing wounds can be a big issue. You're often dealing with a skin surgery and then we radiate it, and it can make that wound or the site of the skin surgery difficult to heal. It can sometimes create new wounds also. Radiation therapy can make you feel a little sluggish, a little tired. It can cause color changes in the skin. Sometimes it can cause burns in the skin, and down the road in the long term can sometimes make the skin get firm and thickened. But it's a great treatment option. It's an investment in time. So it's not a true side effect, but it's an investment in time for the patients, meaning they're having to come in and get the treatments frequently for a defined period of time. With immunotherapies, we do see a fair amount of side effects, and we are using immunotherapy so much now, we're getting really good at predicting and managing them. A lot of patients who go on immunotherapy, and in fact, almost up to 50% will have a skin reaction. So it's actually a very special position for me and my colleagues as dermatologists to be able to diagnose and help manage a skin cancer. And then if a patient also goes on immunotherapy, we can help them get through their cutaneous toxicities, their skin rashes. Other side effects can include issues with the lungs, the liver, the gastrointestinal system. But again, these are things that all those experts in each of those fields can help manage. And a lot of times we're able to keep patients on their therapies.
And that's why the treatment team is so important, and all the physicians working together.
Yeah.
Okay. Can you help our viewers understand what a clinical trial is, why it's important for patients to find out if there's a clinical trial out there that could be a good option for their treatment, and what role clinical trials play in non-melanoma skin cancers?
So, clinical trials, broadly speaking, are our way to test new treatments, make sure they're safe, and then prove their efficacy. And so in the world of non-melanoma skin cancer specifically, we don't have a lot of options for treatment, at least advanced. And so this is a really exciting new emerging area of research and clinical trial development, is what can we do more for these patients? And so how do you find out about a clinical trial, or do you need a clinical trial? If you have an advanced skin cancer, particularly one that is being seen by a multidisciplinary team or that's being managed at an academic institution, it's actually standard of care that we consider you for a clinical trial. And so certain institutions will have certain trials available. And so you can look at that institution's website, or your provider will know what clinical trials are options to you. There's also a national database, clinicaltrials.gov, where you can go to the website and type in the type of skin cancer, and it'll pull up all of the trials and the sites where they're located. And so this is an opportunity for patients to really be their own advocates as well, and say, hey, I'm going to take a look and see if there are any clinical trials. Benefits to clinical trials are that you may be given a treatment that has been proven to be effective. We just need a little bit more data about it. And so you'd be among the first to get a new emerging treatment. It also helps us help others. The more patients we have on clinical trials, the more data we have to say, yes, this is the therapy that all of our patients need. And now we have the data to support it. And so not only does it help the individual patient by getting, potentially a new advanced effective treatment, it helps everyone else who comes after them.
So some people, as you probably know, some of your patients, when they hear clinical trial, they get scared that they're not going to be getting what they need. Can you tell us, and that's simply not the case, as you described, and as we know, and as we try to inform people at CSC, but can you help us try to alleviate our audience and our patients' fear about when they hear the words clinical trial?
Yes, it feels like you're going to be experimented on. When you say clinical trial, we all kind of have that sense. What's really, and one of the most important pieces of a clinical trial is something called informed consent. And so anytime someone is engaging in participating in a clinical trial, there is a dedicated time and space to sit with a provider, a nurse, or a physician, a clinical trial representative, to go through the entirety of the trial and make sure that you as a patient are fully aware of what you will or will not be receiving, and answer any questions you have. A very vast majority of the time in a clinical trial, the patient is going to receive at least the minimum standard of care, meaning you'll get the care that you would have gotten outside of the clinical trial, potentially, and then some. And so that, I think, can be very reassuring. And of course, the specifics of each trial have to be discussed with each patient, but we would never put someone through a non-standard of care regimen that would put someone at threat. The patients will always be getting standard of care at minimum.
Thank you for explaining that. We have a lot of information at Cancer Support Community on our website about clinical trials and what to ask. So please feel free to refer to that as well. Can you tell us, since you're a leading expert in the field, what other new and exciting techniques should people with advanced non-melanoma skin cancer know about, and what's in development, and what are some recent approvals?
I think what's really important for patients who are diagnosed with an advanced non-melanoma skin cancer to recognize are that this is a very small percentage of a large pool of people that we're seeing. And so getting to a place where you have multidisciplinary care can be quite helpful, because there are new and emerging techniques from the diagnosis alone. How we look at these biopsies under the microscope is changing, how we classify them, certain special tests that we can do. The treatment options are changing. Do we cut the skin out and that's it? Or do we sample a lymph node at the same time? And the decision to do that may not be done at all places, and it really it's a very patient-specific decision. But it's a type of surgery that may help us understand how a patient's skin cancer is going to act and give us guidance on how we need to treat them going forward. As far as treatment options, we've actually had a great advancement in the last really 3 to 5 years in the world of systemic treatment for these skin cancers. Again, I mentioned previously it used to be chemotherapy, and now we have immunotherapy as an option for all 3 types of skin cancer. FDA approved immunotherapies for basal cell, squamous cell, and Merkel cell carcinoma. And we have seen really remarkable improvements in patients on these therapies. patients. In the last decade or so, we've had some new pills, some targeted therapies, as I had mentioned previously, specifically for patients with basal cell carcinoma, and that's often used in advanced cases before we go to immunotherapy, if we can. And then I mentioned some injectables too. There are certain types of injections that we can use to help stimulate the immune system. We can use them independently. We can use them alongside immunotherapy, systemic therapies. And so really, this is a very exciting time for me to be in the world of skin cancer, taking care of patients, because it feels like we really are rapidly advancing how we're managing these patients, from identification to follow-up and surveillance.
Okay. So we know how challenging managing cost is and cost of care for people with cancer and their families. Can you tell us, Dr. Smith, what resources are available to help pay for the treatments and clinical trials that we've been discussing?
This is a very, very, very real and a very big concern for very many patients. And it's going to be a unique scenario for each patient. A patient may have full insurance that just doesn't cover a lot, or it doesn't cover the treatment at the location where the patient wants to get their treatment, or a patient may have no insurance. And so I think, again, understanding that each situation is unique and individual, reaching out to the support infrastructure at the treating facility is the best place to start. And social workers are really our go-to around that. They can sit down with the patient and take a look at the entire picture. How do we get you health insurance? Is there a way we can get you on a plan? Or can we set up a payment agreement? At a lot of institutions, patients without health insurance will get a discounted rate, and then you can set up a payment plan. And that offloads that financial burden, which can be a barrier to accessing care, a very real barrier to accessing care in a lot of these cases. The nurse navigators who are helping to coordinate these visits can also help to direct the patient into the social workers realm as well. But utilizing our social workers at the cancer centers is one of the best resources we have to helping to develop a financial plan for treatment.
Excellent. What are some of the other challenges when you're working with your patients that you see that they're facing, and what barriers exist, and how do you give them guidance?
I think for my patients, knowing that I see patients who are immunosuppressed and have a lot of skin cancers, there is a very real thing called surgical fatigue, where we're chipping away at multiple different spots, trying to stay ahead of the game, trying to capture, skin cancers before they become problematic. And again, while each little surgery is small and minor, that it's a wound that a patient is dealing with for 6 to 8 weeks, and then I bring them back at the 12-week mark and do it all over again. And a lot of our patients who end up making advanced skin cancers also have multiple early skin cancers. And so just an overall fatigue with the process is very real. A lot of these skin cancers are growing in cosmetically sensitive areas, the head, the neck. And so some of the surgeries we do can be disfiguring. And that has a great emotional burden on the patients. Again, we have great resources in a cancer center to help a patient through that. But things such as moving your face, making facial expressions after a big surgery, looking different, having trouble speaking clearly at first, that can be a very real struggle for a fair number of patients. Where I work, we see a lot of patients from rural communities, and the commute, the drive, a 2-hour drive for one visit isn't a huge deal, but a 2-hour drive every single day for 5 or 6 weeks for radiation therapy is a very big deal. And not just from a time standpoint, a fatigue standpoint, but a financial standpoint too. So distance traveled and just a disruption in your routine can be a real challenge for patients.
So like you said, I think, what the one great piece of advice is that there are people out there, your nurse navigator, your healthcare team, your social worker, who can help with transportation, who can help with costs, who can help refer you to counseling and other things, support groups, and things that are out there for you and your family to help you get the support that you need while getting the care that you desperately need as well.
Yeah, definitely.
What do you recommend to our listeners regarding skin screenings and other suggestions to avoid and/or detect and treat skin cancer early on? It used to be that you should get a skin screening once a year, but I know that that's changed in terms of some of the leading societies in terms of the recommendation. Can you speak a little bit to that?
Yeah, you are correct. So, unlike a colonoscopy, a pap smear, a mammogram, a skin screening is not recommended for every single adult in the United States. And there are reasons for that. However, there are individuals who would benefit from a skin screening. And again, so it's not everyone, but people who are at higher risk for making skin cancers. And I have mentioned some of them previously: fair skin, history of sunburns, history of tanning bed use, which is becoming a more and more prominent risk factor in my generation and the few generations ahead of me, for sure. And so patients who are immunosuppressed should be getting skin screenings, absolutely. Patients who have made a skin cancer. So if you've made one basal cell skin cancer, you need a yearly skin screening. A family history of melanoma definitely warrants routine skin screening. Having lots of moles on your body warrants a skin screening. And so these are, things where our national guidelines aren't going to say that it is absolutely, mandatory, but these are things that our Academy of Dermatology has recommended for high-risk patients, annual screenings. And we know anecdotally, we can all recount at least even one patient a week or even a day where they come in for a skin screening and we find a spot they were unaware of. Catch something early, which is what we want to do.
Absolutely. That's great advice. So now for our viewers, it's a great time if you have any questions to drop them in the chat box. But before we open the forum to open questions, I have one more question, Dr. Smith. What else do you want to make sure our viewers know about advanced non-melanoma skin cancer? And 5 to 10 years from now, if we were come back and do a Facebook Live together, what would your hope be?
Well, I think what I want my patients and patients who are diagnosed with an advanced skin cancer to know, or an advanced non-melanoma skin cancer to know, is that seeking out a multidisciplinary care team is of utmost importance. And this actually comes from our national guidelines, our NCCN guidelines. Will say multidisciplinary consultation is really, really beneficial. And that's where you're going to get the most thorough advanced care. And you might have to advocate for it. And that may be, going to a bigger city, seeking out the academic institution closest to you, but there are great multidisciplinary teams at non-academic hospitals as well. Also, I would want patients to know that it can be very scary. I didn't speak to that earlier, but this is a very scary situation to be in. Cancer is a scary word. But know that largely, even with an advanced non-melanoma skin cancer, our treatments are such that patients can do quite well. 5 to 10 years from now, I am so excited. I think that we're going to be managing these advanced non-melanoma skin cancers in ways more akin to how we manage melanoma, which is a very linear pathway. We've got great guidelines, patients get great treatment. And we know with melanoma now, 10 years ago, our outcomes were very different compared to what we have now, largely thanks to immunotherapy, but also our staging techniques are improving care too. With non-melanoma skin cancer, I think the initiation of the use of immunotherapy is going to make really great improvements for patients who have disease that has already spread elsewhere in the body. I'm excited to see how we can use it to prevent it from spreading. So I used that word adjuvant earlier. I think that knowing who's high risk and making sure they're getting the right adjuvant treatment will hopefully help prevent cancers from growing back or spreading.
Okay, perfect. So a few questions that came in. Can you tell us what's considered an early diagnosis?
Yeah, so early just means we can treat it easily with skin surgery, cryotherapy, which is where we freeze spots, scraping, creams. Again, skin cancers that are small and that have not spread elsewhere in the body or that don't have potential. There are some types of basal cell skin cancers that can be a little on the larger side, but we know they're not going to spread or cause trouble. So skin cancers that are small, confined to the skin, and don't have the potential to spread elsewhere in the body. That would be an early skin cancer.
Okay.
And a very large majority of skin cancers we see are early.
Okay. Can you just reiterate for our audience what family members should know and what actions they should take if their relative or parent has a history of a non-melanoma skin cancer? I know you touched on it, but if you can just reinforce that idea.
I think, for the patient's health themselves. So if you have a loved one or a first degree relative who has made an advanced non-melanoma skin cancer, again, that doesn't directly increase your risk of making one. However, the genetics that gave your loved one fair skinned and made them at risk from making a skin cancer could also make you at risk if you are also fair skinned. With the genetic risks, there are some rare cancer syndromes that run in families, where if you have a relative who made 20 basal cell skin cancers before the age of 30, then you might have a genetic syndrome that makes you at risk too. And so it's not a bad idea to have a skin exam if you have a loved one who has made a skin cancer, particularly an advanced non-melanoma skin cancer. I think more importantly is the support that that loved one can provide their family member as they go through treatment. And we think of skin cancer as being no big deal. And largely it is, and we like to keep it that way. But just know that there are a small subset of skin cancers that are a big deal. And it can be a lot for a patient to go through. And the word skin cancer is not just going to be a minor ordeal for everyone.
Okay. And one last question. Somebody wrote in that they've heard that if they have a lot of moles on their body, marks on their body, that it is sometimes recommended that they get full body pictures that they can bring every year to their physician. They might not want to, put it up on the wall, but they can, have it, bring it to their physician, and that can really help the physician kind of look over their body, saying, did this change or is something new? Do you recommend that?
Yes, this is a phenomenal technology that has actually been around for quite some time, but is still sort of in its infancy as far as broad scale implementation, because it's kind of hard to find a place or a facility that offers that technology. There are really great apps that can be downloaded where it will guide you through taking pictures of your own skin and store those photos securely within the app. As you mentioned, you don't want to be flipping through your photo album and find pictures of the moles on your bottom. But there are apps that can help you document those. I do think in the next 5 to 10 years that total body photography is the technology we're speaking of will be widespread in use. Where there are techniques already available where a camera, even from your iPhone, can pick up and capture and track spots and dots on the skin and can run that image through an artificial intelligence algorithm and can say that spot is 1 millimeter bigger, that spot is new from last time. And so this is a really exciting area of technology for me that I hope I can offer to my patients soon. It's also something where you can just take photos on your phone and keep them. And again, that can be helpful too. If you have a new spot that wasn't there 6 months ago and you have documentation of it, that's really helpful in prompting you and prompting your physician to take that spot seriously. So yeah, total body photography is a great way to track people with what we call busy skin, meaning lots of spots and dots. It can be tough, really tough for anyone to keep track of them.
Perfect. That's amazing. Dr. Smith, we can't thank you enough for your time for joining us today. The information and insights you've shared are without a doubt invaluable to both me, CSC, and our listeners. So thank you so much.
Oh, it's been my pleasure. Thank you for having me.
Absolutely. And thanks again to our sponsors, Regeneron and Sanofi. It's been my pleasure having you today for this great conversation. If you have any questions about advanced non-melanoma skin cancer, making treatment decisions, targeted therapy or immunotherapy, or anything else we've discussed today, or just generally about cancer, please connect with our experienced and licensed navigators at our cancer support helpline. That number is 888-793-9355. I'll repeat that. That's 888-793-9355. And you can also visit our website, cancersupportcommunity.org. Dr. Smith, and to our audience, a happy, healthy, and safe holiday and Happy New Year.